I started to realize that I had a whole clinic full of people that went to the most prestigious hospitals in the United States, and they were told that they were psych patients, and they were making it up, and they were prescribed anti-anxiety medication, antidepressants. I mapped it. I have 1,000 pages of maps of the body. It shuts pain off different areas of the body. Even actually have a money-back guarantee course for that for shoulder pain, so you can just try it out. And if you can't, my guarantee is if you can't relieve the pain of the majority of the people you attempt the method on, and increase range of motion dramatically, then you get your money back, no hassles. In my sacral paper, I wrote 57% of the 19 patients that I outlined in that paper had thought about ending it all because they just got so tired of it. Yo, everybody, what's up? Physical therapist, Dr. Ryan Whelton, coming to you from the very hot Tampa Bay area. If you are new to following me, I am a physical therapist. I got a clinic where most patients have failed everything type clinic, or close to it type thing. And I get exceptional results in that patient population. I made discoveries. I published a good amount in the Journal of Practical Pain Management, which now became Med Central. I believe they changed the journal name, but if you go to wheltonmethods.com and just go to publications, you can read my papers right there. And then I also have all kinds of online courses of these maps of the body that I stimulate a point here on my patient type thing, shuts pain off, at a certain joint angle and angle of pressure. I mapped it. I have 1,000 pages of maps of the body. It shuts pain off different areas of the body. Even actually have a money-back guarantee course for that for shoulder pain, so you can just try it out. And if you can't, my guarantee is if you can't relieve the pain of the majority of the people you attempt the method on, and increase range of motion dramatically, then you get your money back, no hassles. I had somebody the other day comment that they took it and something like 29 out of 30 shoulder patients it worked on. Awesome. Makes me happy. So anyways, it's been a huge help in the clinic. And then I have, that's my myofascial courses. And then I have my instant pain relief sciatica, cervical radiculopathy courses, my course. And then I also have my Rehab results course, which is my orthopedic protocols, which is what I do in here to get exceptional results with my patients. And then I have my business, results-based business course. I am creating a membership, and I'm going to teach live again, but I'm going to do it online, where I teach something, every week type thing, and then also have. So I'll teach every week, but then also you'll be able to bring your patients in, and the whole group can learn. And my goal is to get people diagnostically on point, and fixing these issues that are falling through the cracks. So I can tell you what the medical system's missing, because in my practice, like just today, yesterday, the day before, people are like, yep, I tried everything. I call it the story: physical therapy, chiropractic, injection, surgery, orthopedic surgeon, neurosurgeon, x-ray, MRI, massage, acupuncture, repeat. Yeah, I hear that story all the time. And the main things that I treat are SI joint dysfunction. I published a paper on that. Okay, it's called Root Cause of SI Joint Dysfunction. It's on my website, wheltonmethods.com, which I find usually goes hand in hand with sacral torsion shear. That is not an accurate way, in my experience, to diagnose SI joint dysfunction is the injection or whatever test, cluster test or whatever. Years ago, I was working with patients, and I started to realize that I had a whole clinic full of people that went to the most prestigious hospitals in the United States, and they were told that they were psych patients and they were making it up, and they were prescribed anti-anxiety medication, antidepressants, and one patient was prescribed Haldol, which is an antipsychotic. And they'd come here, and I'd pull in their leg for their upslip, gap open their out flare, rotate their sacrum back, boom, pain's gone. And I'm like, no, you weren't crazy. I'm like, they just, the medical system is missing this, and anyways, like this week, I've seen several patients with the similar story. It's pretty wild. So I see SI joint is mechanical back pain, things that don't show up on X-rays and MRIs. The medical system's great at structural issues. You got a tear in a cartilage, they'll diagnose it. I also had a patient that I saw yesterday that had I was shocked. She had a tear in her left knee and kept complaining of knee pain. And God bless this orthopedic surgeon she went to, who said, yeah, I don't think that's causing your pain. And she had pain up higher there. And he said, I don't think that's causing your pain. I think it's coming from your back. Even though you have this meniscal tear, I don't want to do surgery. And I'm like, wow. I'm like, good for that surgeon, because he was right. So I opened up her SI joint, boom, her knee pain went away, leg pain went away, her groin pain on the other side went away when I opened up that SI. That she told me a physical therapist laughed at her about that, saying that I have this groin pain because they didn't know what to do about it, right? It was all SI, but I have seen patients that have had, I've had patients that have had their knees operated on, and the surgeon said clinically it was a success surgically, but the person was still in pain. Open up their SI joints, boom, pain goes away. So anyways, I tell people, from anybody with any symptoms from the lower thoracic into the foot, including the groin, into the foot, screen them for SI. You know what you can actually do is you can, if you're unsure and somebody has any symptoms from there, just put them on my protocol. It's 4 exercises, just add it to it, and it's kind of like a prophylaxis type thing. You know what I'm saying? So I see that. I see rib head misalignments, that these people are in sharp pain in their mid back, and it radiates around, not nerve, it radiates through their through their ribs, actually. And I see that a lot. And I got a guy right now that he's almost completely better, doing much better, wrapping around. MRI was negative, and I sprung his ribs, held his rib cage open on the first visit, boom, pain's gone immediately. He doesn't have any more back pain, And I'm like, yeah, no, it was this. It doesn't show up on x-rays and MRIs. And then I see headaches, stress-related, neck tension, stress-related. I see thoracic outlet syndrome, actually. Usually a good handful of times a year, I'll see somebody that's been to neurologists and you name it, physical therapists, chiropractors, and no one screened for thoracic outlet syndrome. And they have their whole hand is numb. And I ask them, is your hand numb when you wake up in the morning? Because they close up the thoracic outlet. And they say, yeah. But yet they had like a herniated disc at C6, 7, something like that. I'm like, that doesn't make any neurological sense. If you have a whole hand that's numb, you would need multi-level herniations to make that happen in the dermatome chart. So that doesn't even make sense. Like there was something else going on, right? Anyways, it's been interesting over the years, but the kicker is if you know how to diagnose this stuff, then they're solvable, and you can help relieve the suffering of these poor people that I see in here that are usually desperate. And then in my sacral paper, I wrote 57% of the 19 patients that I outlined in that paper had thought about ending it all because they just got so tired of it that I just discharged a lady that told me that when I evaluated her. With SI joint. She's happy, she smiles now, and that to me is the most rewarding thing about this job, is to see someone that is originally miserable, just pain, chronic pain, so tired of the medical system. This lady told me, I don't trust doctors, I don't want anything to do with them, they're all wrong, but my husband dragged me here. and here I am. And so anyways, she had SI joint, sacral torsion, sacral shear. I rotated it back and, realigned the upslip, got open the out flare like in my paper I wrote, and and then her pain was gone immediately, and then we stabilized it using my protocols, and she is now better and smiling, which was something that I told her on the last visit. I said, "You're smiling. This is the first time I've really seen you smile." She's like, "I just walked around an amusement park, She's like, "This is amazing." So it's really these conditions devastate people's lives, but it's on us. It's us. We're the ones that deal with mechanical issues. Surgeons deal with structural issues, but we're the ones that deal with mechanical issues, and we need to be able to help these people. So, anyways, that's that. I could go on forever about mechanical back pain and SI joint sacral torsion shear and thoracic outlet syndrome and all these things that are being missed. But today I am talking about Achilles tendonitis. Now, I think it was 2021. I think it was 2021 that I published a paper called Root Cause of Plantar Fasciitis. So generally, over the years, I generally don't have trouble getting that better. And years ago, I had this insight. I was working with a patient, and something made me check intuitively their posterior capsule of their TC joint. So tibia, TC joint right here, posterior capsule tight. And I noticed that all these people had hypomobile TC joint capsules, right? So I was like, this is throwing off the physics of the foot, causing plantar fasciitis. So I started stretching it, right? And then along with the calf stretch and the gastrocnemius soleus that I outline in my paper on my website, wheltonmethods.com, root cause of plantar fasciitis paper. And I then boom, 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 patients were getting better. And I was like, woo, I think I'm onto something here type thing, right? And so then I started checking patients with Achilles tendonitis. So Achilles tendonitis, what is it? It is your Achilles tendon, okay? Your Achilles tendon that goes from here up into your calf, that gets inflamed. Now, when it comes to tendonitis, okay, people, if you think about what it is, it's an overuse syndrome. And what I have found, and outlined in my paper, what I have found is that the reason why they're being overused is because there's usually a joint capsule tightness. So, like in my shoulder paper that I wrote on posterior impingement syndrome, I also say for bicipital tendonitis, all this stuff, is that I write in there that the posterior shoulder capsule and inferior sometimes is being too tight, is causing an overuse syndrome of the bicipital tendon or whatever I outlined in the paper. You can read it. And what I've found to be the root cause of Achilles tendonitis is gastrocnemius soleus tightness, which most people stretch that when they go to rehab. But also I have found as important, if not more important, is their posterior capsule is tight. So do the posterior draw test. And next time a patient comes in, they got Achilles tendonitis, what I want you to do is put this here, okay, hand here, grab their tibia, and grab the non-affected leg, okay, and the leg with no pain, and you'll feel a spring, right? That's a normal play of the TC joint, the posterior capsule, right? And then grab the one that is affected, and it's like this. You can't move it, okay? And so what's happening is that the joint capsule is getting strangled, okay? So it's strangling the joint, okay? And therefore causing an overuse syndrome. And the way that I show my patients is so that they understand it. I say, let me see your hand. And I go like this. And I say, you can even see it. I'm like, do you see how I can't dislocate your wrist? Because there's a joint capsule right here preventing me from doing that. And then I go like that. And I say, now go ahead and go like this. And I'm like, much harder, right? And they're like, yeah. And I'm like, imagine how long it would take before all the tendons get irritated. And they get it. And I'm like, that's what's happening. Okay. So the way that I rehab that is the same as my plantar fasciitis protocol, minus the boot. You don't got to wear the boot. Okay. You do for plantar fasciitis, but not that. And so there's basically 3 exercises. Like a lot of the stuff is made really complex, and it doesn't need to be. That's one of the things that people say to me about my rehab results course is they're like, it's so simple. And I'm like, yeah. I'm like, I've whittled it down over the years of what I need and what I don't need. And I'm not interested in fluff. Never have been a person interested in fluff. It's a waste of time when you are doing exercises that you don't need to do. So I whittled it down, and I got these protocols down to just a few exercises type thing, 3, 5 exercises usually, and that usually does the trick for me, as seen in my papers. So anyways, you need to stretch the joint capsule. Now, for years, I would stretch their joint capsule with my hand, and I would go home and my hand would be throbbing. And I would like groan every time I would have to do this, because I'm like, man, like I'm gonna have arthritis in my thumbs. Like, this hurts, man. So anyway, so then I caught on to Mulligan's technique with mobilization with movement, and I threw in a bike tire tube, and that I outlined in my paper. They were kind enough, thank you Mulligan for letting me outline that in my paper. And the person can do it at home and create joint play, doing it that way. And a lot of times they feel better right after doing it. Okay, so when it comes to Achilles tendonitis, you have to stretch the posterior joint capsule, but you also need to stretch the gastrocnemius. But you got to get that to 10 to, usually I write in the paper, 10 to 12 degrees of active dorsiflexion, okay? 10 to 12 degrees of active dorsiflexion. Now, I don't put people in pain. I don't believe in it, with the exception of total joint replacement, surgical stuff where you have to get the range of motion back type thing, frozen shoulders. I do not put patients in pain. And the reason, like there's this, research that says if you do eccentric contraction, help it heal faster. No, not me. I do not strengthen someone that has Achilles tendonitis. I do not have them do calf raises. I do not do anything to irritate the tissue. The tissue has been overused. It needs to rest. And I tell my patients that they need to rest while we're doing this. Most don't want to rest, but I tell them they have to rest, okay? Because rehab is a non-linear process. It's like this, as they get better, worse phenomenon. But when someone is not resting while we're doing this and doing all kinds of crazy things, right? It goes like this. Like that. They throw their back out or whatever. They flare the whole thing up. They rip their plantar fascia again. And it's like, okay, let's calm it down. Stop what you're doing. Let's start over again. And that's why I believe a lot of rehab fails when the therapist or the clinician was on the right track with their rehab, but they didn't shut them down. And if you don't shut the person down, then they're going to irritate it and they're going to blame you. So that's how that works. I have been doing this 20 years, and I have had thousands and thousands of patients, and I can tell you that's how that usually goes. Okay, but you were on the right track. It's just that they did something, they threw their back out, and then it's like your fault type thing. So I just keep them in a bubble. Okay. Okay, so rest is beyond important. Do not put patients in pain. If you put patients in pain, you are irritating the tissue, and it takes longer. So I have these protocols, like in my rehab results course, I say like generally takes, 5 to 8 weeks or whatever for each condition or whatever I outlined. But if you put the person in pain, those timetables are skewed. Those timetables, you'll see, those timetables get skewed. So if you start adding things to my protocols and have them do like calf raises when they got Achilles tendonitis, I'm telling you, you're going to irritate this thing. Okay. You need to think about what you're doing. You're trying to calm something down and take the strain off of it, but then you strain it while it has a tight posterior capsule, which is overusing it. That doesn't make any sense in Achilles tendonitis. So you can't do that. Okay. But if you just follow along in my protocol, I mean, the students I talk to are like, yeah, I don't have any problems with it, getting these patients better. So anyways, check the posterior capsule. And then also in the inner tube, outlined in my paper, my Rehab results course, in the inner tube, sometimes it can irritate them over the Achilles, like the tube comes around their Achilles and they have Achilles tendonitis, so it kind of hurts, like pushing on it, right? You just got to bring it up to a point that it doesn't hurt. I had a patient that I had to do that the other day with. And it hurt the Achilles, so I just moved it up on her, and it didn't hurt, and she was still able to do the posterior capsule stretch, which is pulling the tibia anteriorly, which is pushing the calcaneus posteriorly, which is stretching the posterior capsule in that Mulligan technique. So, anyways, I recommend reading my paper and share it with everybody you know, and let's stop people's ankles from hurting because it's just crazy what people are having done. I have people that have, all kinds of injections and all kinds of crazy stuff, and it ends up just being a tight posterior capsule, doesn't show up on X-ray and MRI, right? And then also always screen for SI joint dysfunction, or just put them on my protocol, but always screen for SI joint dysfunction, because you can get, ankle type pain in there, so that's that. Anyways, peace. Love you all.